Yes, I'm starting to record it.
Perfect. Well, thank you, everyone, for being here. This is the first event that we're doing in this, what is planned to be a series of events, the TSC Educational Series. I'm just double checking to make sure I got the name right. This is an initiative that I should highlight is being led by Robin Whitney. Just want to make sure I have everyone's name. Robin Whitney by at McMaster, Maria Zach at Sick Kids, and Miriam Nouri at Western University in London, and myself. So the idea is that this is meant to be a forum to present on certain topics relevant to tuberous sclerosis, to have this as an ongoing series, for it to be online, so accessible to anyone across Canada, for it to be accessible and also, to as much as possible interactive. It's the place to ask questions. As we go along, we'll be inviting different experts to present. The audience, however, is not, of course, other doctors. The audience is not nurses. The audience this is meant to be for patients and for their families, for children and for adults. So for those of you who don't know me, I'm an adult neurologist. I'm in Montreal. I'm at the university. Trying to translate in my head, the CHUM. So the Hospital Center for the University of Montreal. And I run our TSC clinic for adults. And now it's my job, my pleasure to introduce my colleague, my friend, Philippe Major, who is the director of the TSC clinic at Saint-Justin. It's in large part thanks to Philippe Major that I developed my own interest in TSC. Our adult clinic was created because there was a need with Saint-Justin's very active TSC clinic. Philippe is a trained neurologist. He's a pediatric neurologist. He is an epilepsy specialist, but his training was not just in epilepsy, but it was in fact a clinical fellowship in epilepsy and TSC at, I guess it was at Boston Children's.
It was at Mass General.
Mass General. And I was thinking about it. You've always said Mass General, and I was like, do they do pediatrics at Mass General?
Yeah, it's so huge that there's a Mass General for children. So it's...
okay. With Elizabeth Seals. And so now, of course, Philippe has a very active academic career, full professor at the University of Montreal, something I'm not, that's for sure. And we collaborate on a number of different initiatives. I'm very fortunate. So tonight, he's going to talk about diagnosing TSC and understanding its cause. I'll leave it to you, Philippe.
Yeah, thanks, Mark, for the introduction. It's always a pleasure to work with you. So as you said, this presentation is for families and persons living with TSC. So I prepared this presentation with that in mind. So at any point, if there are things that either you don't understand or you want more details, or you don't, feel free to interrupt me. I think we're only 13 people, including 2 doctors. So it's a small group. So don't hesitate. Okay, at any time. Yeah, so let me just should work. Yes, so mandatory slide disclosure statement. So just a bit of history. I think it's interesting. So it's, of course, like many diseases, except maybe COVID, it's not a new disease. It was described in 1880 by this young man, Dr. Bourneville. Who was a pathologist, and so when he looked at the brain of people with the disease, he thought that the areas where there were brain malformations looked like potato tubercules, hence the name tuberous sclerosis. As you know, it's a genetic disease, autosomal dominant. So I'll explain later what autosomal dominant means, and it's characterized by extensive development of benign tumors in multiple organs and by brain malformations. So the diagnosis, as I will explain, and as you probably know, is based on a set of clinical criteria in addition to a genetic test. And it's rare, but it's not that rare. So it's 1 out of 6,000 live births. So it's the second neurocutaneous disease in terms of incidence. The first one being neurofibromatosis type 1, who has an incidence of 1 in 3,000 live births. So we jump directly into the cause of the disease. Here you see the two genes, TSC1, also called hamartin, and TSC1 tuberin. TSC1 is on chromosome 9, TSC2 on chromosome 16. And you can either have we now say a pathogenic variant, but we used to say a mutation in either TSC1 or TSC2. And we find a pathogenic variant in approximately 90% of patients. For the 10%, the remainder of the patient with no mutation identified, we don't think that there is another gene. We think that it's probably what we call germinal mosaicism, which is a kind of just a mutation is just in the reproductive cells, basically. TSC2 is twice as common as TSC1. The gene is a bit larger, which could explain why it's more frequent. One main characteristic of the disease is that the phenotype meaning the severity of the disease, is very, very variable. We see patients with almost no sign or symptom, and others, as you know, who have refractory epilepsy, autistic spectrum disorder, etc. On average, people with a TSC2 pathogenic variant are more severely affected compared with patients with TSC1. But it's always like a bell curve. So you can see people with TSC2 variant who are mild and TSC1 who are severe. So it's very hard to predict the phenotype. So just a quick lesson about, so it's genetics 101. On the left, it's autosomal dominant. So we have 2 copies of every gene, one coming from the father and the other coming from the mother. And with autosomal dominant diseases, you just need 1 copy with the mutation. Here in blue, like this seems to be the mother. She's affected. So you cannot be a carrier in autosomal dominant diseases. You're affected or you're unaffected. So if you have the disease, 50%, there's a 50% chance for every child that you have to have to be affected, to have the pathogenic variant. So you have these 2 people who are unaffected and the 2 others who are affected, and then they can transmit it the same way. Contrary, or it's different from autosomal recessive. So autosomal recessive, you need to have the 2 pathogenic alleles in order to be affected. If you only have 1, like these parents, you're considered a carrier. So if you have so for children, the probabilities will be that you'll have 1 affected child, 2 carriers, and 1 unaffected child, if both parents are carrier. I hope it's clear. It's clear to me, but sometimes it can be a bit confusing. This is also a very important slide in order to understand what causes TSC. So basically, you have the TSC1, TSC2 protein complex that doesn't work well in people with TSC. And normally, it inhibits mTOR. So mTOR stands for mammalian target of rapamycin. It's a protein that you see in many, many cells in the body. And mTOR protein has many roles. It's involved in control of cell growth, angiogenesis, glucose uptake metabolism, cell orientation, and migration. So when mTOR was actually kind of discovered, and when it was found that it was the protein that was not well regulated in TSC, very quickly people said, okay, rapamycin, we know that the other name is sirolimus, and then so researchers used rodent models of TSC, and they just tried sirolimus for these on these animals, and it worked. So it worked for the kidney tumors, like they decreased in size. So this was a big discovery. And after that, also everolimus was tested. So both can be affected, can be effective at inhibiting mTOR and controlling mTOR, hence helping a few manifestations of the disease. So there was a big discovery because TSC was considered a genetic disease with no specific treatment. The treatment was mostly symptomatic, meaning you have this problem. We don't treat really the cause, but we treat the consequences. So just a bit of a history in terms of the clinical diagnosis. So as I said, the disease was described in 1880, and then German neurologist Voigt proposed the classic triad in 1908. And so this triad was seizures, mental retardation, and angiofibromas. It was a start, but the triad was complete only in 29% of patients, while 6% had none of the three signs. It's a problem when you choose criteria that are not very specific. Seizures are very common. Mental retardation is very common too. So that's why later there were multiple iterations of diagnostic criteria, and I'll tell you the last version dates from 2021. This is just a retrospective review of 278 patients that were evaluated at TSC clinics at the Children's Hospital and Massachusetts General Hospital in Boston. It's just to see the age at diagnosis. So the age range was very wide, like from birth, or even I could say before birth, when we diagnose a cardiac rhabdomyomas in utero, and you could diagnose also the oldest person was 73. And I think I know this. I think that I saw this person. Actually, we diagnosed the child, and then the mother, and then the grandmother. It was a very mild phenotype, fortunately for them. So the mean age at diagnosis was 7.5 years, but the diagnosis was mostly made before the age of 10. It's rare that we make a diagnosis in adults. The most common signs and symptoms at diagnosis are seizures. So other than infantile spasms, if we add the infantile spasm, which is a form of epilepsy, 13%, we have 60% of patients are diagnosed because of some form of epilepsy. You can also be diagnosed because you have a family history of TSC, cardiac rhabdomyomas in utero, or sometimes our colleagues in dermatology send us patients with hypopigmented macules. So as previously said, so there were a set of diagnostic criteria in 2013, but the last iteration was in 2021, published in Pediatric Neurology. So this paper is easily available. And yeah, so there's the genetic criterion. You have a TSC1 or TSC2 pathogenic variant. As I said, sometimes there's no mutation. I previously said 10 probably 10 to 15% of patients for whom we don't identify a mutation. Or there's the clinical criterion. You need definite diagnosis. You need 2 major or 1 major and 2 minors. Possible diagnosis, 1 major or at least 2 minors. And these are the criteria. So there are minor criteria and major criteria and minor criteria. As you see, I put skin and brain. So you have 4 criteria involving the skin and 3 involving the brain. 1 involving, so the retinal hamartomas, the eyes, 1 cardiac, 1 lungs, and angiomyolipomas, either in the kidneys or the liver. And you have this set of minor criteria. So I'll just show you a few slides about different clinical manifestations of the disease in order for you to better understand the phenotype. So this how it is. So facial angiofibromas, so that it's the same person. So the picture at 4 years of age, and then 8 years, and then 21 years, just to show that it's not usually a big issue in children, but it can be prominent in adults. Fortunately, we have treatments for that, like the topical sirolimus. Maybe this person did not benefit from this treatment, but it's not dangerous. But socially, sometimes it can be difficult. The other skin manifestations. So on the left side, you see very clearly the hypopigmented macules. You can also see the shagreen patch, which is the area of thickened skin, usually in the lumbar area, like this. This woman on the upper right part has fibrous plaques on the forehead. She has a few of those, and she also has the facial angiofibromas. At the bottom, it's a bit blurred, but you can see the periungual fibroma. So you can have these fibromas if you're not very good with a hammer and you just punch your thumb or something, and it can be traumatic, but patients with TSC have them spontaneously. Renal lesions. So these are kidney MRIs. The kidneys, I don't know if you see my my arrow, but these are the kidneys. And on the left, you have a 30-year-old woman with multiple angiomyolipomas. So it's made of angio vessels, myomuscles, and lipomas fat. These are quite extensive. And at the bottom, you see cysts in a 10-year-old. So the angiomyolipomas, they're more common in people with TSC2 pathogenic variant. Why do we worry about them? It's because when they increase in size, the risk of hemorrhage also increases. These are not cancers, but we worry about the risk of hemorrhage, and usually we suggest an intervention when the diameter is between or at least 2 or 4 I said millimeter here, sorry, it's a mistake. It's 2 or 4 centimeters. Very important. Please correct this. And the treatment usually is mTOR inhibitors, sometimes embolization, and we don't recommend nephrectomy for these patients because you lose too much normal kidney function. Then the other renal manifestation is cysts. There are 2 modes of presentation, either single or multiple small cysts. It's the most common mode of presentation, and usually there is no clinical consequence. But sometimes you have patients, especially those with large deletion that encompasses the TSC2 gene and PKD1 gene, and these patients can have high blood pressure, and sometimes they can have renal insufficiency. I have 2 patients who eventually needed dialysis, unfortunately. This is rare, but it's a more severe presentation. The heart now, so these cardiac rhabdomyomas are benign tumors that are found in half the patients. 2/3 of patients have multiple lesions. They're often found in utero. And it's very interesting because contrary to other tumors, they're more prevalent during infancy, and they spontaneously regress after birth. So logically, there's an influence of the maternal hormones in utero, and then after birth, without this hormonal milieu, there's most probably it's the explanation why they regress. Usually they are asymptomatic, but sometimes when they are not placed at the right place, they can affect blood flow and sometimes heart rhythm. We've had 3 or 4 patients in the last 15 years, I would say, who needed, for whom we tried successfully everolimus after birth, just to kickstart the spontaneous regression, and it worked quite well, and these patients were published. There's also lymphangioliomyomatosis. It's very hard to pronounce. I have to say I had experience with that when I was doing my fellowship in Boston, because I saw children and adults, but now that I see only children, I haven't seen this for a while. So, but I know that this is a cystic degeneration of the lungs, and the main symptom is lack of breath when you do an exercise. So this is the main symptom, but it's usually diagnosed when we do a CT scan of the lungs, like this scan. Yes, so LAM can occur sporadically, but it's more specifically associated with TSC, usually almost exclusively in women with TSC. Again, the hormonal influence in TSC. Yeah, so only 2 to 5% of women with TSC are symptomatic, but there's a much larger proportion, 35 to 50%, who have LAM on CT. So the available treatments, mTOR inhibitors, it has been published in good journals that it can slow down progression, but it's not yet accepted as a formal indication by Health Canada. And unfortunately, a few patients needed lung transplantation. Now, the brain. So these are brain MRIs. Just to show you what tubers can look like you see the white arrows. So you see these white spots. They can, so the number is very variable. The size is also very variable. And sometimes people say, well, if there's a tuber in this specific area, will this affect this function or this function? It doesn't really work like that. Like, for example, if you're an adult and you have a stroke in one specific area, your language can be affected, your motor skills. But these lesions, the tubers, they're formed very early during gestation. And because of that, and because of the concept of brain plasticity, so the fact that the brain can reorganize itself, when we examine patients with TSC, even though there's a big tuber in the motor strip of the brain, for example, we don't really see like motor deficits or increased reflexes or things like that. Sometimes we can, but usually we don't. Now the subependymal nodules, so the green arrows, so you can have them near the ventricular lining. When they're in the back, we don't really care about those, but when they're located near an area called the foramen of Monro, which is basically the opening of a little duct where the liquid circulates, we worry about them, because the ventricular system is like a system of lakes and rivers, and when you have a dam at one point, when, for example, exactly this sega is not very well placed. It's exactly near the foramen of Monroe. It just blocks the circulation of fluid, and it can cause intracranial hypertension, a complication that we really don't like. So patients, when they have intracranial hypertension, they have a big headache, nausea, vomiting, fatigue, and the reason why we do regular MRIs is just to see if these subependymal nodules start growing, and if they start growing, we want to intervene before the patient needs emergent surgery because of intracranial hypertension. I have to say that in the past 15 years, with proper screening, with regular MRIs, we have had no patient coming emergently to the hospital in the state of intracranial hypertension. So basically, when we see a nodule growing that is growing near the foramen of Monroe, we usually start everolimus, and it works very well. And this has really changed our practice. Just to show, so tubers, as I said, so these are brain malformations. They contain abnormal giant cells with neuronal glial markers. They form very early during gestation, and they're considered static lesions, meaning that they don't grow. Sometimes they can become a bit cystic or a bit calcified sometimes, but they don't really grow. They don't really change much. Still talking about the brain, epilepsy is very prevalent. And most patients with TSC have epilepsy, and I'll give you more details about the type of epilepsy. Half the patients are considered cognitively normal, or to have a normal IQ. A normal IQ is IQ that is above 70. And in TSC, there are two peaks. So there's a peak where people have a very kind of, we say, a profound mental impairment, and another peak where the curve is a bit skewed to the left. So we can see it in two ways. So half the patients are considered cognitively normal, and half the patients have mental impairment. Autistic spectrum disorder is found in 20 to 30% of patients. It's, again, a spectrum, so there are more milder form and more severe forms. And there's a notion of, so TAND is a TSC-associated neuropsychiatric disorders. So as you know, in addition to epilepsy, mental impairment, autistic spectrum disorder, you can have also, I'll show you the next slide. So this umbrella. So you need to consider all these aspects, if I can say that. So behavior, psychiatric, intellectual, academic, neuropsychological, psychosocial. So this slide really just helps you touch on all the important aspects in terms of TAND. And there's a checklist that we can use in clinics just to screen for these issues. Going back to epilepsy, as I said, 60 to 90% of patients are affected by epilepsy. A third of them have a history of infantile spasms, which is a specific form of epilepsy that can affect babies, really characterized by spasms, like either inflection or extension form. And these spasms need to be recognized early, because we want to treat them ideally as rapidly as possible. And there's a medication called vigabatrin, that is particularly effective to treat those in TSC. It's also an epilepsy that starts early. So 2/3 of patients have had a diagnosis of epilepsy during the first year of life, and 2/3 of patients have refractory epilepsy. And the definition of refractory epilepsy is having failed at least 2 anti-seizure treatments. So the age at first seizure. So we looked at all the patients that we had in our database at the Mass General in Boston, and the median, so most patients had their first seizure when they were 3 months of age. 63% had their first seizure during the first year of life, and only 12% had started their epilepsy after the age of 18. So really a problem that starts during childhood, basically. And the other interesting fact is that all the patients who had a first seizure went on to have a second one after that. I'm saying that because in clinics, in people who have only, so we see kids who have their first seizure, and we usually don't start an anti-seizure drug for these patients because the risk of having another one is around 30% if the EEG is normal and 50% if the EEG shows epileptiform discharges. But for patients with TSC, the risk is very, very high that, in fact, in these patients, they all had a second seizure and hence they were considered epileptic at that point. So this is important to keep in mind when you discuss about treatment after a first seizure in patients with TSC. So I refer you to this nice article published in 2018 about the management of epilepsy in TSC. So these are clinical recommendations. In terms of medications, vigabatrin is more effective to treat infantile spasms in patients with TSC compared with spasms associated with other causes. So important to know. There's a lot of discussion about preventive treatment. There are 2 studies that have been recently published with not the same results, and this is still a bit discussed. We're not really sure about what to do at this point. mTOR inhibitors, everolimus is the one that was studied the most, especially in the EXIST-3 study and other studies. I won't go into details about treatment because my assignment was to talk about diagnosis and kind of clinical manifestations and things like that. But if you have questions, I'll be more than happy to answer your questions. Surgery should be considered for patients with refractory epilepsy. It doesn't mean that every person will be a good candidate, but they should be considered, especially that in well-chosen patients, 55 to 60% can become seizure-free, according to this paper and according to a few others. Oh, sorry, I forgot to translate those, but ketogenic diet is also good option. It's one of the best treatments that we have for refractory epilepsy of any cause, so it can always be proposed. Vagal nerve stimulator also can be good option, but very rarely it renders your patient seizure free, unfortunately. But it can decrease the seizure frequency and sometimes improve global level of functioning. Cannabidiol is approved by FDA, and a lot of researches and good papers were published by my ex-mentor, Dr. Thiel in Boston, and it's also a reasonable option that we can propose. So I'll just kind of talk to you about
a really
yes?
quick question.
Yes.
Just because I feel like I'll forget if I wait till the end. When you say CBD there,
Yes.
that's approved by the FDA, is that Epidiolex?
Yes.
Or it
Yes.
is?
Yes.
So it's approved, like that is an option in Canada then, Epidiolex? Or no?
So not yet, but hopefully it will be, because Epidiolex is approved by FDA and also by the European Council for epilepsy, refractory epilepsy and tuberous sclerosis complex, in Dravet syndrome, and Lennox-Gastaut, and the company is at the moment filing an application to Health Canada to have it kind of approved. But so far in Canada, what we've done is so because we don't have access to Epidiolex, we prescribe CBD, but it's like the yellow oil that we're using, and we're not really sure if it's the same, because we feel when we look at the studies, it seems that it causes more somnolence, and because the yellow oil has 20 parts CBD and one part THC, and the THC is the part that causes more hallucinations and somnolence and things like that. Epidiolex is supposed to be pure CBD. So hopefully our patients in Canada will have access to Epidiolex soon.
Yeah, that's good to know. I asked because we actually tried CBD, and we found some benefit, but it's very expensive. So I just wondered. I had that on the slide. I wondered if it was approved. So thank you for.
And the one big issue is cost, of course, and I think the province, so in Quebec is different than the rest of Canada, and so there's the CADET, or the Canadian Agency for Drug and things. Probably the company will submit something to see if the government can cover, hopefully at some point. So there are many options. It's always good to have all these options, and sometimes so it's not one size fits all, as you know. So depending on the patient, depending on this and this, there are pros and cons. So like, for example, when we started to using yellow oil, I mean, we didn't know if you start a kid on this at 5 years, we don't have data. So we started with patients who were very, very refractory, for whom we felt could have some benefit, and we're able to live with the potential risks of impairing development or other aspects. Yeah, that's a good question. So multidisciplinary management, basically. So what makes this disease complex is that, first, there are many clinical manifestations, and they don't appear at the same time, at the same moment during a person's life. So you need different. So I put only the doctors here, but of course I'm not forgetting social workers, physical therapists, occupational therapists, etc., etc., etc. So that's why you need coordinated multidisciplinary care. And this is the schematic representation that I have in my head. And I think it's very similar for Mark. We consider ourselves like the TSC hub. Usually we work with a nurse. I work with Lucie Côté at Saint-Justine, and we have the patient family in our team, and then we have all the other people, other physicians, professionals, lay organizations. We have the schools, rehab centers, and there are educational opportunities, research opportunities, and we try to work with that scheme in mind. And just if you're interested to know about our models, there was in Perspective by TS Alliance in winter 2022, just an article about our clinics in so the pediatric side and the adult side with Mark and his friends. So in conclusion, I think I'm good on time, so we can have time for questions. It's an autosomal dominant disease with variable phenotype. I hope that you've understood what's dominant compared with recessive. 2/3 of patients have inherited the pathogenic variant from a parent. I don't know if I mentioned that, but 2/3 it's a genetic inherited from a parent, while it is de novo or spontaneous for the other third. And since 2013, in addition to clinical criteria, you can diagnose someone with a positive genetic test. And I feel that a multidisciplinary approach is essential for a complete management of TSC, and to have the best care for our patients. I think for the moment that's it, and I hope you've hopefully learned a few things, and I'm open for question.